Well, it's truly a privilege and honor to be with you this morning. I'm going to talk to you a little bit about the clinical rationale for using surface-guided radiation therapy for stereotactic radiosurgery. Here are my disclosures. I'm going to start off by saying that I think we all recognize there is a truly revolution going on in oncology, and that, of course, in radiation therapy, there is a lot of changes, but in particular in the setting of metastatic disease and improvements in systemic therapy, there is no question that there is a revolution going on. And there is, I think, a greater and greater realization that metastatic disease is becoming more of a chronic illness than a death sentence. This has a lot to do with improvements in systemic therapy and targeted therapies that are really improving survivals in patients with stage 4 cancer. We see them all the time. They're living longer. And one of the effects of this is that these patients are developing brain metastases in a way that we've never seen before, simply because in a lot of disease sites, they just weren't living long enough to get brain metastases, and now they are. An example is what's happening really over the past 5 or 6 years now is the introduction of Herceptin for HER2/neu directed therapy for breast cancer. This alone has improved survivals to the point where maybe 3 or 4 years ago, we started seeing many patients with breast cancer with brain metastases that we never used to see before. So this is just one example. Really, some of the greatest breakthroughs at ASCO have to do with targeted agents, small molecules, antibodies, all kinds of immunotherapy, all kinds of things that are really improving survivals in our patients with stage 4 cancer. And it is truly on its way to becoming a chronic illness. And many of my patients who have stage 4 cancer, we've been treating those patients for 3 or 4 or 5 years or longer. We just published a paper on patients who had spine radiosurgery, and the median follow-up on this group is 6 years. And these are patients who had spine metastases. Ordinarily, you would have thought that the median survival in this group, the first paper we published, was like 11 months. So there is a revolution going on in oncology. One of the things with brain metastasis was that there has been an arbitrary cutoff on how many brain metastases was reasonable for radiosurgery, and when should you switch to whole brain radiation. And I have to say that a lot of the randomized trials that looked at radiosurgery had a cutoff about 3 or 4 metastases. Now, you wonder, well, why was that? Where did that number come from? Well, I think it really had more to do with practicality for LINAC users than it really was. It really wasn't based on biology. If you were a LINAC user and you wanted to treat 4 isocenters or more than 4 isocenters, if you wanted to treat 10 isocenters, it would essentially tie up your LINAC all day to do that. It was just impractical. So that cutoff of 3 to 4 metastases, which really, for a number of randomized trials, was more of a technical or a practical cutoff than it was biologic. Gamma knife users would routinely be treating multiple 10 or more metastases, and then the LINAC users would say, oh, that's insane. You know, that doesn't make any sense. If you're going to treat that many, you might as well give the patients whole brain radiation. So there's always been this tension about how many brain metastases is reasonable, and I have to say that I think I'm going to show you data to suggest that it really wasn't based on biology or oncology, but really on practical limitations of the technology. Let me just start by saying, what about starting with 1 metastasis? Is it reasonable to omit whole brain radiation? And this is Roy Patchell's second study that he published in the New England Journal in the late 1990s, where they took patients either with craniotomy alone or craniotomy for single metastasis and whole brain radiation. And what you can see here is that in terms of overall survival, there was no difference in outcome, whether or not you withheld whole brain radiation. There certainly was a difference in local control. But in terms of overall survival, there was no difference in omitting whole brain radiation in patients who had a solitary metastasis in the brain. So these patients actually recurred within the brain and particularly within the surgical cavity frequently, but you did not compromise survival by emitting whole brain radiation. And one of the interesting things about this study was that if you did have a recurrence and you crossed over, if you were in the surgery alone arm and you got delayed whole brain radiation, then that did not affect your overall survival. And so it made it seem a reasonable proposition that you could withhold whole brain radiation up front and, in a sense, use a delayed strategy to, when you had disease progression, then get whole brain radiation without compromising survival for that patient. So this is a paper, an old paper now from Penny Sneed, where they took 10 institutions who pooled their data and looked at their outcomes not after craniotomy but after radiosurgery. And the question was, in a retrospective multi-institutional database, could you withhold whole brain radiation the same way that it appeared you could after surgery in Roy Patchell's randomized trial? This is of almost 570 patients who are in this study. About half of them had radiosurgery alone, and about 25% of those patients had salvage whole brain radiation. The rest of them had whole brain radiation and radiosurgery up front. What this study found was there was no significant difference in survival. In other words, if you withheld whole brain radiation up front, or if you needed it later, had a delayed whole brain radiation strategy, in this large multi-institutional database, you did not compromise survival, and that was true for every prognostic category. This particular paper used the RPA classification, and whether you were a favorable group or an unfavorable group, there was really no difference in overall survival by withholding whole brain radiation and just using radiosurgery, keeping whole brain radiation as a salvage option in the future if there were further recurrences. One of the reasons why it's an attractive option to withhold whole brain radiation is the perceived concern about the effects of whole brain radiation on neurocognition. So this is a very interesting study done by Eric Chang when he was at MD Anderson. They did a small randomized trial taking relatively favorable prognostic patients with up to 3 metastases, and they were randomized to either getting radiosurgery alone or radiosurgery and whole brain radiation. So remember, this is up to patients with 3 metastases. They reduced the dose per fraction to try to minimize the impact of the dose per fraction on neurocognition. So these patients got 2.5 gray per fraction in 12 fractions when they were in the whole brain arm. And this is what they found. What they found was actually kind of interesting. In the long term, there was a difference in overall survival in favor of omitting whole brain radiation, which is kind of odd, right? Like, why would patients where you omit whole brain radiation do better? But in terms of developing new metastasis, there certainly was an advantage to whole brain radiation up front. But in the long term, that advantage disappeared. So, but certainly there was a benefit in terms of new metastasis. Whole brain radiation reduces the risk of new brain metastasis, and that makes sense. What they found actually also is in some ways counterintuitive. Yes, absolutely, With radiosurgery, you had about a 50% difference in decline of neurocognitive function by using the Hopkins Verbal Learning Test. So if you omit whole brain radiation, you have a much better chance of having better cognitive functioning. However, you got to remember that these patients are also developing new brain metastasis. So if they're developing new brain metastasis, why is it that their neurocognition is actually better? And is it possible then that it would be reasonable to admit whole brain radiation even though you're taking the chance of developing new metastases if you can follow these patients closely and intervene if necessary? So if I were a radiation oncologist practicing in Brazil, I don't know if we have any, is Brazil part of our community, Todd? Not yet. Okay, that's on your list for next time. If I had a patient from the Amazon and they were going to see me once, I would probably give them whole brain radiation because I'm never going to see them again. But if I'm going to be able to follow that patient and intervene with new metastasis, actually for survival advantage, there's no disadvantage to admitting whole brain radiation. And they will develop new metastases at a greater rate, but if they do, I can intervene. And I can save neurocognitive functioning by about a 50% difference by omitting whole brain radiation. So this small randomized trial was actually terminated early because of the difference in neurocognition in favor of omitting whole brain radiation, and also because there was a survival advantage to omitting whole brain radiation. So based on this small randomized trial, the conclusion was that for 1 to 3 brain metastases, radiosurgery alone is preferable to whole brain radiation in addition to radiosurgery. Now, there are probably other strategies. Could you use other strategies to save neurocognition and still give whole brain radiation? Even though, remember, the whole brain radiation is not buying you better survival. What about memantine, which has been advocated particularly by the team at MD Anderson? Well, memantine can possibly give you a 10% likely benefit with or without it, except it costs $1 billion to do. And so we don't actually use it in our clinic because it's so expensive. But if you give someone whole brain radiation, maybe there's a 10% improvement in neurocognitive decline. Compare that with the 50% difference by simply omitting whole brain radiation altogether. And there's been an interesting paper that's come out suggesting that radiosurgery is itself a cost-effective treatment. And you might think that, well, isn't radiosurgery with close observation actually going to be more expensive? But it's actually not. It is more cost-effective to avoid whole brain radiation and give radiosurgery with observation. It fits within the definition of what is considered a cost-effective treatment in terms of quality life years. And in fact, I'm sorry you probably can't read this in the back, but this is a little blurb from Astro suggesting that in choosing wisely as a patient, you ought to consider omitting whole brain radiation. So we have some data for, let's say, up to 3 or 4 metastases. But what do you do in the setting when a patient has 5 or more brain metastases? Should radiosurgery be considered? Well, if you're at UCSF, they've been treating up to 15, 20 metastases with their gamma knife routinely for years and omitting whole brain radiation. And if you ask Dr. Sneed to give up her gamma knife, you're going to have to pry it out of her dead hands whenever that time comes, because they have been using radiosurgery alone for multiple metastases as part of their clinical care for many, many years. Why would we consider it? Well, radiosurgery probably offers better local control, especially for radioresistant histologies, than conventional fractionated whole brain radiation. You certainly can spare a dose to the uninvolved brain, and I'm going to go over that in a minute. As we've seen, there's less toxicity, particularly neurocognitive decline, and our medical oncologists do not like the intense fatigue that patients get after whole brain radiation. And then our melanoma service will actually refuse to allow their patients to get whole brain radiation. They would rather have them die a neurologic death than get whole brain radiation, which in their mind just causes toxicity and no benefit. But what about the whole brain radiation? Certainly reduces the risk of new metastases. What about the risk of leptomeningeal disease? And resource allocation is an important practical question. Well, here's a paper that really helped convince me that we really should be switching our practice away from whole brain radiation and going to radiosurgery for multiple metastases. This is a trial that was published 2014 in Lancet Oncology for multiple gamma knife centers in Japan. Now, they say this was prospective. I think I would take that with a little grain of salt. But it was almost 1,200 patients. And these patients had up to 5 to 10 metastases. They used the mini-mental status exam. I don't know why in Japan they love that. It's a really terrible way to assess neurocognitive functioning. But the Japanese just love it. The median survival was reasonable, about 12 months overall for this large cohort of patients. When they did a non-inferiority analysis, what they found was that actually there was really a significant difference between one metastasis and more than one. That's where the cutoff was. It wasn't at 3 or 4, which a lot of the randomized trials had indicated. Really, the difference in outcomes was really based upon whether you had a solitary brain metastasis or you didn't. And in fact, there is really no significant difference in outcomes if you have 2 or more metastases. You could have 10, and the outcomes are not that different from whether you have just 2. Where the big dividing line is 1 versus more than 1. For example, if you look at the likelihood of developing new metastases, if you have 1 metastasis, there was a significant difference than those who had 2 to 4 or 5 to 10. However, there was really no significant difference between 2 to 4 and 5 to 10. So if you were comfortable treating a patient with up to 4 metastases with radiosurgery, you should feel equally comfortable about treating patients with 10 metastases, because there's no difference in the likelihood of developing new lesions, whether it's 2 to 10. The big difference is 1 or more than 1. What about leptomeningeal disease, which is another real strong absolute indication? Well, I should say that it's certainly a exclusion criteria for radiosurgery. Does the number of metastases predict the risk of developing leptomeningeal disease? And so if you missed out on the whole brain, have you done your patient a disservice because of the risk of leptomeningeal disease in the future? Well, again, it's the same issue. If you have more than 1 metastasis, your risk of developing leptomeningeal disease is really not different than if you have 10 metastases. The dividing line is 1 and less than 1. And in fact, there are randomized trials suggesting that in subset analysis, if you have 1 metastasis with a controlled primary, those patients may actually have a survival benefit with whole brain radiation. Perhaps in those cases, you shouldn't omit whole brain radiation. But certainly if you have 2 or more, the risk of leptomeningeal disease is not that different if you have 10. There is an increased risk with 10, but it's not a big difference. It's maybe a 10% difference between 2 to 4 and 5 to 10. In terms of any mental status, as I said, I don't think this is a good way to assess neurocognitive functioning, but certainly there was, again, no difference whether you treated 10 metastases or you treated 2 metastases in terms of developing worsening neurocognitive functioning after radiosurgery. So what their summary was, again, foregoing whole brain radiation may be an option and up to 10 metastases. However, I would point out that this data has a couple of problems. One of them is that they don't have really complete follow-up, including imaging follow-up, and I don't think their toxicity follow-up was very complete either. But nonetheless, I found that this data was very compelling and made me think that perhaps in our clinic we should be thinking about moving to treating multiple metastases of radiosurgery and emitting whole brain radiation. This is particularly because the technology has developed to the point where it's becoming just as easy to treat 10 metastases with 1 or 2 isocenters as it is to treat a single lesion. With VMAP planning, it certainly is much more feasible. It doesn't take up time on the linear accelerator to treat 10 or to treat 1. They're about the same. And with the treatment tools that we have, we can develop very sharp dose fall-offs that are very similar as if you were to treat 10 lesions with 10 isocenters. So here's an interesting paper from University of Alabama at Birmingham, led by John Fivash's group. And what they did is they took gamma knife plans and compared them with VMAP plans for multiple brain metastases. What they looked at is plan quality at isodose levels as well as the mean brain dose. And let's see. Okay, well anyways, on the left is gamma knife and on the right is multi-arc VMAT. And you can see that the distribution clusters very similarly whether you're a gamma knife user or if you're a VMAT user. If you do the planning appropriately, you can essentially recreate gamma knife plans, except you can do it in a single or 1 or 2 isocenters, maybe 2 to 4 arcs. So let me just go over a case. This is multi-lesion VMAP plan. And just to show you the stark difference in doses to the brain, even for multiple lesions. So this patient has 6 lesions. We did a 4-arc VMAT radiosurgery plan. And so this is set at 300 centigrade or higher in the posterior fossa where there are multiple lesions. And the prescribed dose here is 21 gray to each lesion. And so the deep blue represents the 300 centigrade isodose line. And remember, this is this patient's complete treatment. So just think, what would it be if you gave this patient whole brain radiation? So this is, let's say we did 300 times 10 to the whole brain. Most of the brain is getting absolutely less than a single fraction of whole brain radiosurgery, except that with the radiosurgery, the treatment's done. This patient would be, incomplete whole brain radiation, single fraction. So you can see that a significant proportion of the brain is getting much lower than even a single fraction of whole brain radiation. Except in this patient's case, this 1 fraction is treatment done. So if you look at the dose volume histogram for the entire brain, Of course, with whole brain radiation, the whole brain gets 100%. But with radiosurgery, this is a single fraction, 300 centigrade. You can see that the proportion of the brain that gets 300 centigrade is, probably running less than about 15-20% at most. So there's a dosimetric reason why patients do much better in terms of neurocognitive functioning, lack of toxicity, by avoiding whole brain radiation. There's no loss of overall survival. There's significantly less dose to the whole brain, and that's why there's less toxicity. And we now have the tools to make this type of treatment eminently practical and feasible. And in my mind, there's no reason why we shouldn't be doing radiosurgery for multiple brain metastases. But there are some problems, especially if you have a frame-based system. Not everybody's anatomy is going to allow you to place that frame properly. And this is a reason why we really moved to frameless radiosurgery, is because of some of these considerations. Patients are missing parts of their bone. They can have burr holes from prior surgery. They can be on steroids for a long time, and actually there's very little room to put a frame low down in the posterior fossa. Or they can have severe arthritis, ankylosing problems in their spine, and you literally cannot put their neck down low enough to connect them to the treatment couch because of the configuration of their neck. And so there are a number of anatomic issues with frame-based radiation, apart from the thing that it's painful for patients and very uncomfortable and really not conducive to multifraction treatment. Just want to give you an example of what happened. One of the reasons why I decided we really needed to switch to a non-frame-based situation, and that image guidance was probably an appropriate way to go for cranial radiosurgery. So this is a patient with bladder cancer who had this relatively low-lying cerebellar metastasis. We put a frame on this patient, and we prescribed 18 gray to 80%. Again, this is a Linac-based treatment with a BRW frame. It's a relatively good plan, it was just a big mistake on my part. When we came to put the localizer on, we couldn't get it on because he had a pretty prominent nose, and we didn't realize that until we actually came to put the localizer on the patient. We couldn't clap it down to the frame because his nose was in the way. So he's obviously he's not very happy with me. I should have known better. And so what should I do? We can't get the localizer on. So now what? Well, we actually converted it to an SGRT plan. Didn't need the localizer at all for image guidance, and we treated the patient. And so we did a cone beam setup and did stereotactic radiation with the BRW frame as the immobilization device, but we got rid of the need for the localizer with image guidance. So he did very well. And there are a number of frameless systems that are out there. The skull, as we all know, is an excellent fiducial marker, and with image guidance, you're not restrained by any physical limitations of the patient's anatomy. Now, we did a number of studies looking at how good actually is frame-based radiation. Everybody assumed that in a frame there was absolutely no movement. That was just assumed. Because it's on there so tight, how could a patient move? Well, actually, it's very interesting that if you look at it, these patients actually moved quite a bit in the frame. I was surprised to see how much movement there actually was in the frame-based system. So what we did is we took a small number of patients that were immobilized in a stereotactic frame, and we simply did cone beam imaging of these patients at the time of treatment and compared them with the CT simulation scans that were done in the morning. our workflow, we would put the frame on in the morning, we would do the simulation CT immediately afterwards, and then we did the plan, and we're ready to treat those patients probably in the mid-afternoon. And so that much time had passed, the patient's just sitting quietly, waiting for us to treat them with the frame on their head. They've had breakfast, they've had lunch, they're waiting for treatment, and then we would put them on the table and did a cone beam scan and overlaid those scans. And what we found as actually pretty surprising, that there is a significant amount of motion with the frame. So if you matched up to the localizer, then the anatomy was off. If you matched up to the anatomy, then the localizer was actually off. There was rotational errors and translational errors. And this was actually a bit of a surprise to us. So in panel B, for example, you can see if you match up to the bony anatomy that this patient has had a rotation. And so what we did is we looked at, again, a small number of patients and looked at the setup accuracy based on serial cone beam scans for patients in a stereotactic frame. And there certainly was, up to about a 2 millimeter potential error in rotation, and that would be clinically significant, especially if your clinic practices without a margin. I mean, that's potentially a problem. So unfortunately, our physicists lost that data, so we never published it, which is really too bad, because I think it's a unique data set looking at the ability of a frame to hold the patient. But certainly we felt that image guidance was really the way to go. I felt much more confidence as a treating oncologist if I could actually see what we were doing rather than blindly following coordinates and setting up to a laser. So as I'm sure we all do, we use surface monitoring as a way to make sure that these patients stay in the right position when we move to a frameless system. So this is a paper that we published a while ago now, suggesting that this was really a very good way to monitor patients during radiosurgery to confirm that once we got them to the right position, that the patient stayed in the right position for treatment. And I have to say that this is really the missing piece that we felt we needed in order to move fully to frameless image-guided radiation. And now with the combination of Vision RT and a 6D couch, we are very comfortable treating multiple metastases, feeling that we are able to give treatment as planned. Here's one of the early studies that we did looking at the comparison between frame-based translations and rotations compared to frameless translations and rotations using Vision RT to monitor the patients as throughout their treatment. And so these are all individual patients that are tracked, and we did the same patients with a frame and without a frame, and just monitored them to see what happens. So you can see that there's at the top, frame A and B are translations and rotational changes that were noted for the same patient. The same patient is tracked in the same color. And in the two bottom panels, you can see the rotation and translation for frameless. And if you compare frame to frameless, both for rotation and translation, you can see that the same patterns occur for the same patients. In fact, there's really no difference between the ability of a frame or a frameless system to hold the patient in the right position. Patients have individual tendencies for setup variation. And this is the pooled data for our patients. And you can see that whether it's frame-based or frameless, that the pattern of rotations and translations that were noted were very similar. And so with this kind of data, we felt very comfortable with Align RT to go ahead and go fully to a frameless system. And we have not used the frame for a couple of years now. And in fact, they came and asked me, well, what are we going to do with it? And I'm not sure what we're going to do with our frame. I think we maybe will send it to the Smithsonian. I don't know. It's absolutely critical that we have certainty that our patients are not moving once we set them up in the right position. And again, I don't think it would make a difference whether it was frame-based or frameless, because we see the same kinds of errors. But here's just an example of a multiple metastasis patient. If we're using an isocenter, let's say the isocenter is set right in the middle between this one lesion in the front and one lesion in the back. If there's a 1 or 2 degree rotational error to the right, you can see how much drift there would be at 1 or 2 millimeters. If you have a 2 degree rotational error, you've essentially missed the small lesion. And believe me, if you ever sat at the console on someone getting frameless radiosurgery, you know that on occasion these patients are drifting more than a degree. The biggest problem, I think, is really sagittal nod. And so here's what would happen if this patient who has, let's say, an isocenter set at the meeting of those 2 arrows, and one has about 7 centimeters, the other one has a 6 centimeter, like a lever arm. What would happen if you had 1 or 2 degrees of sagittal error, rotational error? Well, that's what it would look like. You know, it would be that, and that is essentially a 2.4 millimeter and a 2.1 millimeter targeting error with a 2 degree rotation. And so this is just a simple trigonometry to show what would happen if you had either a 0.5 degree, a 1 degree, up to a 2.5 degree rotational error with either 3, 5, 8, or even 10 centimeters away from the isocenter. 10 centimeters is a bit of a stretch in the brain, but in the setting of multiple metastases, remember, we're talking about not treating 1 or 2 lesions, we're talking about treating 5 to 10 lesions. They're all varying distances away from the isocenter. If you have a small rotational error, you're potentially looking at more than a 2 millimeter error. And so what I've done is, in the red, suggested that any kind of rotation error with distance away from the isocenter would be a concern if you used a 2 millimeter margin. Almost the whole thing might be a concern if your clinic practices without a margin and you miss a rotational error. So certainly, frameless radiosurgery with surface mapping, I think, is really the best of all worlds. Well, actually, the best would be with a 6D couch. And you can be very certain that you're hitting multiple metastases with 1 or 2 isocenters in 2 to 4 arcs if you're able to monitor the patient during treatment with surface mapping. We use radiosurgical margins for hypofractionation as well as for single fraction treatment, mainly because I feel very confident that with the combination of image guidance and surface mapping, we should be able to achieve radiosurgical setups for every fraction for our patient. I think for time, I'm going to actually just stop here and let's see if there's anything interesting that what else I had to say. And I think that the marriage of surface guidance, guided image guided, 1 to 2 isocenters is an excellent approach. It's as good as Gamma Knife. there is absolute rock-solid clinical rationale for avoiding whole brain radiation in many of our patients who have multiple metastases. Certainly we have now the tools to do this in a practical way that's not an impact on resources and can only benefit our patients. And as they live longer and longer, this is going to be a bigger and bigger issue, quality of life, neurocognition, in the setting of multiple metastasis. And so I really feel that this is something we had talked about not too long ago as being like in the future, but the future is now. And I thank you for your attention.